Welcome to Gogolux Preview ADA 2025, and we're just going to talk about some of the late-breaking data and trials which are going to be coming out at the end of this month. So we've picked 4 trials plus a wild card which we think could shape clinical practice in the future.
Now, bear in mind, we're talking about some significant trials actually, and things that really have quite strong implications for us not too distant future. Certainly, we're talking oral GLP-1 therapy, dual combination hormonal combinations, muscle preservation with weight loss, incretin therapy in type 1 diabetes, and even the wildcard gene therapy. So a lot to get through. Patrick, what are you going to be covering?
So I'm going to be covering the orforglipron data, which is ACHIEVE-1. That's the trial which is coming out. It's a phase 3 trial. And another phase 3 trial or set of trials, REDEFINE, using CagriSema. Yourself?
Nice. Leave me with BELIEVE and COURAGE, which are looking at muscle preservation with incretin therapy, as well as SURPASS type 1 T1D, which is looking at Tirzepatide in type 1 diabetes. And then perhaps we'll get time to talk about that wild card.
So let's get into it.
So first up is ACHIEVE-1, which uses orforglipron. It's a phase 3 trial. It's the first non-peptide oral GLP-1 receptor agonist. And we've already got some headline data for this study that showed a 1.5% A1C reduction and an 8% weight loss. So not far off injectable semaglutide. And that's in a pill. So why is it so important? I think this is, as I say, the Beetle car or the Ford 8 or whatever we should do. It's the GLP-1 for the masses potentially. Small molecule, easy to produce, mass produce at that. In the future, imagine a future when it's generic in 15 years' time, maybe. Whether I'll still be around, who knows, probably not practicing. But imagine a world where it would be as cheap as a statin, for example. And this drug, you could be taking any time of day. You don't need a fridge. And maybe there's some deals that could be made with payers to make it more available easier. I've talked about the good stuff. What's the bad stuff? Amar always tells me I've got to remember the bad stuff. So the bad stuff, well, tolerability, how well we've had problems with tolerability of other small molecules. We had a couple drop out in phase 2 and early phase 3, I think, early on. So we need to look at that. Liver signal, I think, is particularly important. They've been told it's well tolerated and there's no liver signal, but that has been an issue cited with danuglipron. So I think we need to stick with that. We won't have cardiovascular outcome data, of course, with this. So that's a caveat we need to be careful with. But I personally feel it's a potential huge step in terms of the future management of obesity and diabetes for that matter. So type 2 diabetes, that is, of course. So that's ACHIEVE-1. Amar?
I'm going to be talking a bit more about the other therapies you can use in addition to incretin therapies. Now, we know we've got a new standard with incretin therapies with combination molecules now where we're getting significant amounts of weight reduction. Now, there's always been a question as what is being lost. Is it just visceral fat? Is it other fat? And also, is it muscle mass? And that's always been the concern. Between 25 to 40% in some studies, the muscle mass is lost with some of these molecules. So again, that's always a concern, especially as you get older, you get more and more worried about your muscle strength and preservation. So these is new class of molecules looking at myostatin inhibitors that prevent degradation of skeletal muscle. And these are used in combination with incretin therapy. So we've got 2 major trials now, really, BELIEVE and COURAGE. So BELIEVE is looking at something called bimagrumab, and COURAGE is looking at a slightly more complicated name, which is looking at trevogrumab without another molecule, garetosmab. So basically, you've got these 2 trials. So in the BELIEVE trial, look at bimagrumab plus or minus semaglutide to show if there's any preservation of lean muscle mass in addition to weight loss. And there's already some preliminary data showing that actually there is benefit with bimagrumab, and even perhaps looking at brown adipose tissue as well. So there's a lot of interesting things coming in with that trial. But further building on that is also the COURAGE trial, which is looking at semaglutide by itself versus dual therapy with semaglutide and trevogrumab, or triple therapy with semaglutide, trevogrumab, and garetosmab, which are all 2 basically molecules which are looking at preservation of that muscle mass. And there's already some preliminary data showing that actually that dual and triple combination preserves between 50 to 80% of that lean muscle mass. So really exciting stuff because we're moving beyond just incretin therapy in weight loss, we're looking at what weight loss we're getting, and also that muscle preservation, which has impact not just in those with type 2 diabetes or obesity, but actually, if you're looking at muscle preservation, what about sarcopenia? What about long-term conditions? This is quite far-reaching effect. So I think the results of this trial will be really significant across medicine, not just ourselves in diabetes and obesity.
So if I move on to CagriSema, so that's of course got, so there's redefined 1 and 2. We've already got the headline data there. If people who don't have type 2 diabetes and are obese, you've got a weight loss of 22.7 and a 15.6% weight loss. Why are we combining those? Well, amylin analogs, which is cagrilintide, in this study, potentially it has some similar effects to GLP-1 agonists in terms of enhanced satiety and gastric emptying. So that combination may be better. We do know there's that drop off, or rather plateauing of weight loss between about 12 and 18 months. So there's this potential of extending that. So it'd be interesting to see what those weight loss curves look like. So that's one of the things I'm looking for. Adverse effects. Well, amylin agonists are traditionally not been brilliantly tolerated, particularly GI side effects, but they, on the plus side again, they have some benefits in postprandial glycemia. So we're going to see even better glucose improvement. So they're all the things I'm looking for. It's phase 3. So this, again, a bit like orforglipron, is on the horizon if the data is impressive to the likes of the FDA and EMA and MHRA in the UK. Really interested in that.
The first one's a bit more standard. It's looking at incretin therapy in type 1 diabetes, so surpass T1D, which is looking at tirzepatide in those with type 1 diabetes. Now, since we've used these molecules, we've always considered, actually, whilst these are type 2 diabetes and those with obesity medication, what about those with type 1 diabetes? We're certainly getting more and more people with type 1 diabetes who are either overweight or in the obese range of BMI. So will these molecules be of benefit? And there have been trials looking at this, looking at adjunct therapy in type 1 diabetes, certainly with the earlier generation GLP-1 molecules. But this is looking at the dual incretin tirzepatide. And there's been some single-center data suggesting there's benefit, up to 10% weight loss and about 0.4 to 0.6% HbA1c. But this is perhaps the more specific randomized control trial looking at it in more detail, just to see whether there's actually some benefit, which we think, I guess you could ask me, there probably will be. It's also the side effect profile we want to look at, that DKA risk, the other side effects we know with incretin therapy, whether we see that magnified or not in those with type 1. So I guess that'll be something quite interesting. But the other thing, and the thing that we mentioned earlier, the Wildcard is really looking at gene therapy in those looking at GLP-1 gene therapy effectively. And this is from a company called Rejuva. So this is Rejuva from a company called Fractile, and it's a pancreatic gene therapy that really delivers a GLP-1 transgene via endoscopic ultrasound. So it is procedure-based, which again, but it's a one-off procedure, and it's a mouse model. So again, it's something for the future, not quite yet. Preclinical model, and it showed it led to sustained fat loss and improved glycemic control and GLP-1 secretion, improved GLP-1 secretion, all from a single dose, a single intervention, basically. And it also is local to the pancreas, it's not systemic. We don't have human data, so it is mouse models, but again, trials could start in the next year or so if this is quite productive. And if you think about that, once one shot GLP-1 gene therapy, no need to worry about further follow-up and ongoing treatment costs, which is again is quite significant. But again, it's all about that side effects and certainly that translation into human studies. So a lot, something for the future, not quite yet, but again, something to be excited about and something for us to talk to.